Hi everyone, my name is Suhaniya. I'm one of the endocrinology research registrars. I'm presenting a paper that was published in the Lancet in November 2021. It's once weekly cagrilinitide for weight management in people with overweight and obesity. It was a multi-center randomized double-blind placebo-controlled and active-controlled dose-finding phase 2 trial. I just wanted to introduce Amylin. So Amylin is a pancreatic hormone. It's co-synthesized and co-released with insulin from the beta cells in the pancreas. It acts centrally and peripherally. So studies that have been done so far have shown that there are various amylin receptors in the central nervous system, and it exerts its effects by mediating the effects on eating and hedonic reward pathways. Receptors, particularly in the area postrema, but also in the hypothalamic arcuate or ventromedial nucleus, ventral tegmental area, and lateral dorsal tegmental nucleus. Cagrilinitide is a new long-acting acylated amylin analog. It has a high homology to natural amylin, and it's thought to reduce food intake and body weight in a dose-dependent manner. So these are some studies that have previously looked at the clinical use of amylin analogs, in particular pramlintide, which you may have heard of. It's licensed in the US to treat type 1 and type 2 diabetics who take insulin. So the majority of the studies on this table include the use of pramlintide versus placebo. And throughout, what we can see, there's a significant reduction in body weight and waist circumference, as well as HbA1c. In particular, the paper by Ratner et al., which was published in 2003, looked at type 1 diabetic patients and found a significant reduction in HbA1c with 60 micrograms EDS and QDS of pramlintide, as well as body weight. An animal study done in 2009 looking at the use of davalintide, which is another amylin analog, and vatamylin, showed that the combination of the two significantly reduced food intake in fasted mice, and also reduced body weight and fat mass in a dose-dependent manner. So the aim of this study was to assess the dose-response relationship of cagrilinitide regarding the effects on body weight, safety, and tolerability of ascending doses of subcutaneous cagrilinitide administered weekly in participants with overweight or obesity to determine the optimal dose of weight management. The primary endpoint was percentage change in body weight from baseline to week 26. Secondary endpoints included change in waist circumference and cardiometabolic parameters, as well as exploratory endpoints such as SF36 and the 3-factor eating questionnaire, which looked at reward behavior and eating habits.
Just tell us, just briefly, the difference between this drug and pramlintide. Are they very similar?
So pramlintide, I think, is a short-acting analog because it's given the patients who take it. The diabetics that take it with meals take it with the short-acting insulin they take with their meals, but it cannot be given in the same pen, so you can't mix the insulin with the pramlintide. So they need 2 injections.
And they're both peptides, are they?
Yeah, they're both peptides, but cagrilinitide is longer-acting.
Okay.
So as I mentioned in the title, it's a multi-center randomized double-blind placebo-controlled active-controlled dose-finding trial. There were 57 sites, which included hospitals, specialist clinics, and primary care centers in 10 countries. The treatment period was 26 weeks. It included the dose escalation period up to 6 weeks, and then a further 6-week follow-up period without treatment. And the sponsor was Novo Nordisk. So male and female adults of non-childbearing potential were eligible. They had to have a BMI of at least 30 or at least 27, plus either hypertension or dyslipidemia. Exclusion criteria was included history of diabetes, which in HbA1c more than or equal to 48, or previous or planned obesity treatment with surgery or a weight loss device. So participants were randomly assigned in a 6-to-1 ratio to either subcut weekly cagrilinitide. The lowest dose was 0.3, and then it was increased weekly to 0.6 or 1.2 or 2.4 or 4.5. Or daily liraglutide 3 milligrams or placebo plus lifestyle modification. So lifestyle modification aimed for a calorie deficit of around 500 kilocalories a day, plus 150 minutes of exercise in a week. Participants and investigators were masked to assigned study treatment, so either active versus placebo, but not to the different active treatments because they had to incrementally increase the dosage. So they worked out that they would need 100 participants per active treatment group to provide a power of more than 99% in order to show a significant difference between the optimal dose of cagrilinitide versus the pooled placebo, and a power of 98% between optimal dose of cagrilinitide versus liraglutide 3 milligrams. They used two estimates to assess treatment efficacy. So trial product estimate, which was basically assumed that in a hypothetical scenario that all the patients that were randomized, the trial continued for the full duration of treatment, which is 26 weeks. And then the treatment policy estimate, which was the effect of being offered the treatment regardless of adherence to treatment. This is just the trial profile. As you can see, there's roughly the same number of patients in each arm of the trial, and the dropouts were fairly similar throughout. The baseline characteristics are similar across all the treatment groups and the pooled placebo in particular: the age, the race, ethnic group, BMI, and body weight. So the results. So this is the primary outcome, which was mean change in body weight. So they found that there was a significant reduction in body weight with cagrilinitide regardless of dose versus pooled placebo, and a significant reduction in body weight with cagrilinitide 4.5 milligrams compared to liraglutide 3 milligrams. This was for the, this was using the trial product estimand. When they compared it with the observed mean reduction in body weight, the results are similar. They also looked at categorical weight loss. So the percentage of patients who lost more than equal to 5%, more than equal to 10%, and more than equal to 15%. As you can see with the cagrilinitide 2.4 milligrams at 26 weeks, 20% of patients had lost at least 15%. And the amount of patients who'd lost about 14%, number of patients who'd lost weight with the liraglutide is what we would expect from previous studies looking at liraglutide. These are the secondary outcomes. So the important points to mention was reduction in waist circumference was greater with cagrilinitide versus placebo in a dose-dependent manner, so 1.2 to 4.5 milligrams, and similar to liraglutide. The HbA1c and fasting plasma glucose improved significantly with liraglutide, and there was a decrease in fasting insulin across all the treatment groups up to week 26. There was also reduction in the effects scores improved in all the treatment groups versus pooled placebo. So these were the exploratory endpoints looking at eating behaviors. So they also looked at the adverse events. What they found, which is sort of unsurprising, is that they found across all the treatment groups, it was higher than with pooled placebo, but it was similar between treatment groups. There were fewer adverse events per 100 years with the cagrilinitide groups, regardless of the dose, compared with liraglutide. So the most common adverse event were GI disorders, in particular nausea, abdominal pain, vomiting, followed by site administration reactions. There weren't any fatal events. There was one case of pancreatitis with liraglutide. The study also looked at anti-cagrilinitide antibodies, and they found that the antibodies increased with dose and time of exposure and was still present after the 26-week period up until the follow-up. The trial follow-up ended at 32 weeks. They seemed to react with the amylin receptors, which were they expected. There were 19 neoplasms, which occurred in 17 participants. That's 2% of the study population, with 5 malignant neoplasms reported. The 2 were in the cagrilinitide group. I think it was 2.5 and 4.5 milligrams, 1 in liraglutide and 1 in the placebo arm. Cagrilinitide is the first long-acting Amylin analog to be investigated for weight management. Treatment for 26 weeks as an adjunct to lifestyle intervention led to a dose-dependent reduction in both body weight and waist circumference. The placebo-subtracted weight loss with 4.5 milligrams at 26 weeks was greater than that reported in other 52 and 56-week trials with other approved obesity pharmacotherapy. In particular, they looked at orlistat. Weight loss with cagrilinitide was greater compared with pramlintide in a study that I previously, it was on the table, Smith et al. They did find that even after patients had stopped taking the liraglutide and the cagrilinitide, they continued to lose weight, although the rate was slower than during the treatment time. There was no weight loss plateau at 32 weeks. Therefore, it's difficult to exclude if further weight loss would have occurred with longer follow-up, in particular if they've been followed up for a year. So in terms of limitations, there was absence of blinding between the treatment groups, and this was because they had to increase the dose escalation for cagrilinitide. The study duration was only 26 weeks, and this is especially important in the arm that was on the 4.5 milligrams, because the incremental dose increase meant that they didn't reach the target dose until week 6. They questioned the generalizability of the study results, given that a high proportion of the participants were white. In terms of further work, future phase 3 trials would investigate use as monotherapy or in combination with semaglutide. So I just put in a slide about the potential side effects of Amylin. So Amylin is a peptide. Studies have looked at the use of peptides and found that in cats who were given the Amylin that it was correlated with pancreatitis. Autoantibodies against Amylin have been reported and more recently shown to be an islet autoantigen in type 1 diabetes. The pramlintide is the Amylin analog that's currently on the market. It has a short life in vivo, and as I mentioned before, is incompatible with regular or ultra-fast acting insulin. Therefore, patients that are prescribed the pramlintide to be taken with the insulin require to inject separate injections at meal times. And it also has a propensity for amyloid aggregation. There isn't any, no one's actually looked at cagrilinitide so far, but it also might exhibit amyloid aggregation, as with other Amylin analogs.
Thank you. You just go back to that last slide. So I mean, amylin is something that people haven't heard of. Would that be fair to say? Even though it's got, I mean, people think of dementia when they hear about amyloid.
Yeah.
But it's amylin. There's a corporation called the Amylin Corporation. Are they involved in this at all?
No? God, I have to check.
Yeah, so, because it looks amazing, really, isn't it? It's non-diabetes patients, and they lost a lot of weight, better than liraglutide. Would you agree with that?
The 4.5, yeah, the 4.5 milligram dose, and they had less adverse events compared to liraglutide as well.
And of course, the fact that you need to give it with insulin is not relevant in non-diabetes patients.
Yeah.
But and pramlintide is licensed for patients with diabetes. So
yes,
you
type 1
got
or type
diabetes.
2, yes, if they're taking short-acting insulin with meals.
Yeah, but it's not in the US. It's not licensed in the UK at all. And in the US, if you have to have diabetes, yeah?
Yeah.
Okay. So there's a long way for it to go, really, isn't there?
Yeah.
But could it have the potential to cause impaired glycemia?
So Amylin, so essentially it works by changing eating behaviors and eating patterns, and changing in rats when they gave them Amylin and they fed them different kinds of food. They found that the rats that were given the Amylin 3 days later, they were still didn't eat the high fatty foods. But in terms of how it changes glycemic control, it works by slowing gastric empty. That's all I can find in the paper.
I think that's one of the licensing issues for the UK, is that because it delays gastric emptying and it inhibits glucagon, there's a risk of hypoglycemia, certainly in type 1 diabetes. So I was just wondering, when you did your adverse effects, Suhaniya, and thank you, that was a really lovely presentation. It didn't say anything about hypos, but I presume that's because these were non-diabetic patients, but that is my understanding about the limitations for diabetes management in the UK, or something that's certainly a concern about amylin analogues in the UK.
They didn't mention hypoglycemia in the paper, but yeah, as you said, I think it's because they didn't look at diabetics, they looked at non-diabetic patients, but they hadn't mentioned. They did say that it didn't have any significant, there was no significant reduction in fasting blood sugar and HbA1c, but fasting blood sugar. Do you think
Yeah.
that they're more likely to have hypos because they're also taking it with a short-acting insulin, and the two together means that they're more likely to get a hypo?
I mean, I suppose just from first principles, you don't often in diabetes clinics see a hypo issue with type 2, do you? It tends to be much, even on insulin, I guess. I'm not saying it can't happen, but clinically, it's much more of an issue, isn't it, with type 1 diabetes? So I suppose if you're insulin resistant and obese, or maybe that presumably protects you a bit against hypoglycemia from this. I don't know actually, but.
So I wonder if pramlintide shouldn't really be used in type 1 diabetes. They've got the wrong market. There's a much bigger market in type 2 diabetes.
I think that's the US licenses for it in type 1 diabetes in the US.
But it's odd given what we've just heard.
Yes, I know. And I don't know enough about the sort of, I don't think it's licensed in the UK. I did have a quick look a minute ago and I couldn't find it.
No, it's not.
And I think it's about these concerns, the hypo concerns. So I don't know if there's more to it from the States data as to why we're not going for it here. It is made by the Amylin Corporation, Corinne.
Well, pramlintide.
Yes.
Yeah.